Good evening, everybody. This is Dr. Di Giunta, and it's a really great pleasure being here tonight. My topic is about injection therapy of the early stage of frozen shoulder. We will put on the key points on 6 areas, as you can see in this one, and now little by little we are going to develop once after the other one. Before the colleague talk about the different stage of the frozen shoulder, and I will focus on the freezing area that is a gap period between 10 and 26 weeks, where we are going to have symptoms that includes really severe pain of the shoulder, especially at night. What we have to pay attention to evaluate the active range of motion and passive range of motion, especially with, if it's possible, with some scores. And what we got usually is a patient that is let me say, psychologically not exactly strong, and this make really the difference. The patient is the ones that you have on the right side of this view. But another key point is that during the injection therapy, we have to really give the appropriate drugs at the appropriate time, appropriate space where we're going to put on. What we usually inject is a steroid, acid hyaluronic, and PRP, and we have many other things, but we will go to focus on this. The steroids. The role of the steroids is anti-inflammatory and analgesics. What we usually do in my personal experience, I usually do 3 injections once a week associated with 10 cc of lidocaine and naropin, which means a big, strong room that we can put in the joint. We have to really be very careful because the effect adverse can be skin burning, skin depigmentation, joint infection. So put everything on a sterile drop on so we can really be safe. The steroids have a short acting, but one of the most used is the triamcinolone acetonide that associated with anesthetics, 1%. This gave immediate pain-free release and can move us on the second steps. But let's say that in these new articles, we can see that the effect of this drug, the steroid, compared with 3 different scores, at the beginning can give a good results, but at the end is the same things. We talk about the SPADI and the score of the constant score and the VAS. Same things happened in this, the corticosteroid, in this review and in this retrospective study is really the good method to understand that we have to put on just this. But let's compare the acid hyaluronics. The acid hyaluronics gave the benefit of the mechanical support and let me say also anti-inflammatory, but we have to use for the shoulder mainly the middle moderate molecular weight, and that is the most used in clinical practice. Again, 3 injections once a week. What I usually do is put some anesthetics, same needles, then I put the acid hyaluronic and then put again some anesthetics on. This way can give more chance to be fluid, and at the same time the hydrodilatation of the joint can be better. We have 2 studies that doesn't give any evidence of superiority of acid hyaluronic compared with the steroids. And we can find this in a systematic review of randomized control trials, and at the same time randomized control trials too. so it doesn't make any difference. The thing is that we have to focus now on where we are going to put these drugs and how. So I can say that what we see in the literature is much easier for who really do everyday arthroscopic shoulder, and probably the posterior approach is the right one, because is the same approach that we usually have for the view of the arthroscopy. Second approach is the anterior approach. Even this can be good because we can have a good right place, safe space between the coracoid and the middle superior portal. The third one is subacromial space. Is safe just for the patients that really have less, it's not really a rigidity very strong, which means that I have 120 of elevation and like 80 of abduction. In this case, what we want to release is just the subacromial space, and we can put the shot right there. But what we realize with our physiotherapists is this: we make the crunchy patient. We understand that we need an assessment. So we start a dialogue with my physiotherapist, and we look around how we can talk about this, how we can make it. So realize the assessment, and in this assessment, as you can see here, can let me say that we can understand what the physiotherapist feel during the section of his physiotherapy, and what he really realize with the range of motion, and if he feels something different. At the beginning, as orthopedic surgeon, I did not really realize what means a crunchy score, but crunchy is a sensation that he can feel it during the therapy. So what we did is this: we realized that one, and is really a good language between the orthopedics and the physiotherapy. This is what we do usually since 5 years already now, and it's a really good method. Also, we have all the clinical data on that. But at this point we have to understand which one are the steps. The steps is assisted analgesic action after injection, just a couple of hours, at least 6 hours after the injection, maximum, immediately physiotherapy, and going to with the object to stretch the fibers. We don't want any effect like anesthesia, like many years ago, or like other people do it, because stretch is something. The risk of do it under anesthesia is to tear the tissue, tear the capsula, and destroy the calf tear, and this is a really great damage for the patient. But this is approved also by our colleague, the first one, that says that additional physiotherapy after intra-articular corticoid injection is really the main treatment in the early stage. I want to show you that a couple of days ago came in my office these patients that you can see here, and at the same time this is before mobilization, just after my visit. And this is what happened. I make the injection, and after the injection, it's not magic. It's just really we had the crunchy test and the assessment, and this is the physiotherapist was as always impressed. And this is the result that we have just a couple of hours after the physiotherapy. You can see she wear the same shirt, so for sure it's at the same times. It's 3 hours after that. So what I'm saying is that we have to tailor the therapy on each patient and work with a good team of orthopedics, physiatric, and physiotherapists. So my take-home message is We have to make a right diagnosis, accuracy, and recognize the kind of patient at the right time. And then early physiotherapy is effective after injection, and customized therapies with a multidisciplinary team that really make the difference. Now, I thank you a lot for your attention. I send you a good view of my Sicilian island. Thanks a lot. Have a good night.